Acute pancreatitis is a very painful condition that is most likely not going to show up in a clinic, but more often in the emergency room. These people are in a lot of pain, and so they're probably going to bypass going to their primary care doctor and go straight to the hospital. The pain is usually in the upper middle abdomen or on the left side. It can radiate to the back. A lot of these people have nausea and vomiting. Some have fever, and almost all of them have exacerbation of these symptoms when they try and eat something. So on the physical exam, they might have hypo or hypertension. So you can have hypotension because some of these are associated with a lot of bleeding or possibly movement of fluid into the peritoneal space. Abdominal tenderness is common, but it's not going to be as much pain as the pain they're having from the pancreatitis. Reduced bowel sounds will show up because of a reflex small bowel ileus, and they may have some jaundice. Gray Turner's or Cullen's sign are both results of internal bleeding, and an epigastric mass may be palpable if they have a pseudocyst associated with their pancreatitis. So if you have these symptoms or some of these symptoms, then there's other things that you need to rule out. Pancreatic cancer can have some of these same types of pain. Cholecystitis will have pain usually in the upper right-hand quadrant, but it's not always that easy to localize. Gastritis might look really similar to this, as well as in irritable bowel syndrome. Spontaneous bacterial peritonitis will have that same type of peritoneal pain. I didn't mention, but the pain is often going to be such that the patients don't want to move. Movement will often make it worse, and that will be similar to the presentation of a spontaneous bacterial peritonitis. Mesenteric ischemia generally will have lower abdominal pain, but it can present similarly to this, and dyspepsia, which is often not quite as severe. So the major causes of pancreatitis are gallstones, alcohol, and idiopathic. The three of those together make up almost all cases of acute pancreatitis. Gallstones, of course, is because the stone gets stuck in the common duct and backs up into the pancreas. Alcohol damages the pancreas. We used to think that smoking might be associated, but smoking is more just associated with alcohol. It's not associated with pancreatitis. And the idiopathic causes represent up to 30% of all acute pancreatitis. So a lot of these people won't go home with a real understanding of why it happened. Hypertriglyceridemia and hypercalcemia both can lead to pancreatitis. There are several types of genetic causes of acute pancreatitis. Lots of different drugs can do it. The AIDS drugs, diuretics, valproic acid, and some chemotherapy drugs all can lead to acute pancreatitis. And there's lots of vascular causes. One of the big ones is splenic vein thrombosis, but there's also any of your vasculitides can cause ischemia to the pancreas, as well as hemorrhage from trauma or tumors. Tumors can block the pancreatic duct. Infection, HIV is a big one, but any type of bacterial infection can also cause pancreatitis, and there is an autoimmune pancreatitis that is fairly rare, but it still is a significant cause. So if we are suspicious of pancreatitis, amylase and lipase tests are the two big tests that we'll want to order. There are other pancreatic enzymes that may be helpful. Your acute phase reactant or your acute phase proteins like C-reactive protein and others may help to contribute to the diagnosis, but really the amylase and lipase are the big ones. Some things might show up on chest film. You may be doing a chest film to rule out other causes. I won't go into the signs that you can see on chest film. The CT scan is really the major diagnostic tool or imaging tool used for pancreatitis. Abdominal ultrasound can help to rule out other causes, for example, just plain cholecystitis. And it can also be used to identify pancreatitis, but that's dependent on how good the ultrasound tech might be. MRI is gaining ground in use for acute pancreatitis, and MRCP is one, and ERCP are both used when gallstones are suspected as the cause. So how do you help these people? The major thing is to help them not to die from the effects of fluid imbalances. There can be a lot of fluid accumulation around the pancreas, and these people will need fluid replacement, or else they can get hypovolemic, and they can get acute tubular necrosis as well as mesenteric ischemia. So that's an important thing to monitor their fluids. Some of them will need supplemental oxygen. Pain is going to be what they're going to be most worried about. They'll be asking for something to help with the pain because it is very painful. As far as nutrition goes, we are moving towards using more enteral nutrition as opposed to parenteral nutrition. It's been shown that enteral nutrition helps to prevent dislocation of gastrointestinal bacteria, and so the more we can use enteral nutrition, we will. Of course, in some patients, they're not going to tolerate it, but in those that do, you can use an NG tube or a J tube, and others will require parenteral nutrition because they won't be able to tolerate enteral nutrition. Antibiotics, prophylactic antibiotics are most often used. It's a little bit controversial whether or not they make a difference, but there is an increased risk for infection due to the peritonitis and the fluid accumulation. So most people will still use prophylactic antibiotics, especially in the face of pancreatic necrosis. Aspiration is again used for pancreatic necrosis, the ultrasound-guided aspiration, as well as necrosectomy to get rid of some of the necrotic fluid and culture for resistance to antibiotics. So because a lot of these are caused by gallstones, and ERCP will be used to both identify the cause as well as to extract the gallstones. Cholecystectomy is commonly used in order to prevent further injury due to gallstones. Anticoagulation may be necessary if you have a splenic vein thrombosis. Of course, that you're going to want to be careful with that because a lot of these are associated with bleeding. And then some of the complications that those who are caused by alcohol will have involve withdrawal to alcohol, so you want to monitor that. You want to make sure you avoid delirium tremens, which is potentially life-threatening. And then upon release, you want to make sure that these alcoholics get some counseling. Please leave comments below the video so we can make these videos better, or you can send them to kendrick@themedschool.com. And remember that these videos are used for educational purposes and not to direct treatment. And thank you.